My name's Stephanie Fish. This is Andrew Gianoukakis, and we're the two chairs for the Fellows course. We're very excited for you to be here and excited for some interesting sessions throughout the meeting. For today, we're going to start with our ultrasound course, and then this afternoon we have a session about different career opportunities, sort of people talking about careers in private practice, academic careers and careers in industry, sort of just as ways for you to have opportunities to ask questions and details about different plans for the future. Throughout the program, one of us will be at every session. Please ask us questions, come up, talk, and let us know how things go. We really want this to be a good experience and hope that you'll learn a lot and also have good opportunities to speak to a lot of different people in different careers, different aspects, and experts in thyroid to answer all your questions.
So welcome again, everyone. I'm Andrew Gianoukakis, as Stephanie mentioned. A couple of things. During the lunch session, those that are basic fellows, and we'll be participating in the Basic Fellows track, which has a few sessions where everybody's welcomed to attend. So there is a Basic Fellows session today at noon. Everyone's welcome to attend if you're a clinical fellow or a basic, but it's geared more for the Basic Fellows. At noon also, there will also be lunch for all the fellows. What we'd like you to do is the lunch should be set up outside here. Bring your lunch in and plan on having lunch in this room, because one of our colleagues, Dr. Castro, who's on the committee that deals with the fellows and training issues and is spearheading our efforts for a special fellows corner that many of you may have already visited on the ATA website. She's going to go through the ATA fellows website called the Fellows Corner with you guys to seek your input with regard to what we have up there and what further suggestions you might be able to make for improvements of the Fellows Corner. So that's the plan for the day, and I'll pass it back over to Stephanie to review how we're going to move ahead with the ultrasound session today.
Okay. So for our session today, we have somewhat limited ultrasound machines today. And so the first thing I just wanted to get a sense from you guys, how many of you are doing your own ultrasounds and are active doing ultrasounds as part of your fellowship training? A lot. Okay. So what I'm going to say here is that the lectures here are going to be review cytology. We're going to review some basic ultrasound. We're going to review some advanced ultrasound. If you often have an ultrasound probe in your hand and are relatively regularly ultrasounding your patients, the hands-on session may not be so helpful to you because there's going to be a lot of people per machine. And so I would just say if that's the case, you're welcome to go back to the general meeting. You're welcome to join us over there, but just so you know ahead of time, we have limited machines today, and so it may not be as productive. So with that being said, we are going to split you into two groups and have one half go over and do the hands-on session where you're going to have demonstration of a normal ultrasound with a machine. You're going to have demonstration of ultrasound FNA. You'll have an opportunity to do a biopsy with a stuffed turkey breast model of a thyroid to get sort of some hands-on experience with that. There's also going to be a station there where you'll have the opportunity to do a cytology specimen using liver, look at it under the microscope, and get a sense of how to prepare slides and things like that. So everyone is absolutely welcome, but I'm just going to say for people who do this all the time, it may not be as productive because it's going to be a lot of people per table. Okay? Okay. So I'm going to introduce Nicole Massoll, who is a cytopathologist at University of Alabama, Arkansas. I was like, oh, I knew it was an A. Arkansas. And so she's going to start and give us an introductory information on cytopathology. Thanks.
So I just want to ask a quick question. In here, how many of you are looking at cytology slides either while you're in clinic, or you go over and look at them with your pathologist? Anybody looking at slides? Great. All right. Anybody making slides after you do the biopsy? Even better. Good. All right. So usually what I start out with is in the regular course, so you guys are starting out younger, you get to learn all this as you go, whereas a lot of them, they didn't do slide preparation and staining and a lot of those things. So there's way more of you in here that are making your own slides and doing stuff, so that's kind of fun. When we start out talking about this, obviously the same things that you need to have for doing your FNA are the supplies you're going to start with to make slides for the pathologist. The big thing to remember is that sometimes these slides end up in alcohol, so when you label your patient information at the top, use a pencil. If you use a pen or a marker, many of those will just wash off in the alcohol. The ones that go in alcohol are typically going to be your slides that get fixed for a pap stain. So if you do pap stain slides, those will definitely go into an alcohol fixative. Your air-dried slides, depending on if you do them in clinic and do adequacy, we'll stop there for a second. Anybody looking at the slides that are stained in clinic to determine adequacy before your patient leaves? Good. Even good. So the air-dried stain that you're doing in clinic is called the Diffquick or modified Wright-Giemsa stain. And it's a very rapid stain, and that's the benefit of it to some extent, is that the pap stain takes about 90 minutes to do. So that one gets done over in the lab with the rest of the sample that you have, and the ones that you make there in clinic and stain are done with this Diffquick stain, and that's what you're going to practice just across the way. Most of the time people do some sort of a rinse, whether it's into a molecular friendly media, cell grow for flow, some sort of fixative cytolite formalin for a cell block or cytospins, that type of thing. And then your requisition form. Many people think the requisition form is just a piece of paper that has the patient's name on it, so we keep the specimen and some way to log it into the computer altogether. But believe it or not, cytopathologists, many of us do biopsies or work with the people that do the biopsies. I do have a clinic and do my own ultrasound guided biopsies, so it's very important to me that on the requisition I like to know the patient's name, obviously, so I can match it to the slide, but I like to know their age, I like to know the side of the nodule, the size of the nodule, the vascularity, the margins, is it complex, what does it look like, all those kinds of things. Did you see calcifications? Did you not see calcifications? Were there comet tails? So the more information you put on there about your description of the nodule, the more that your cytopathologist can fine-tune the diagnosis that they give you, besides just saying it's benign or malignant. Okay, so they really do like that information. I wish I could get this to go. This is what my setup usually looks like in clinic. So I have an empty container over here which holds my dry slides, or the ones I do the Diffquick with. This has alcohol in it, so I put those slides that are going to go for a pap stain in here. This is my stain setup, and you'll see this again shortly. The first container is the alcohol for the staining. The second one is going to be fast orange. The third one is going to be hematoxylin. You can see at the bottom then we have something that we rinse in, and I have my slides there ready to do. There are different ways that you can prep your specimen. The most common way still is the gold standard, which is slide preparation. It can be done either with smears or a book method. Most people are much more familiar with smears. There's another method which is called a book or a pop apart, and I'm going to show you how that is performed as well. We can do cytospins, so the material that you rinse into your rinse media, we can spin down through conical tubes and have a small circle of concentrated cells to look at. That can be used either just for additional cellularity to look at, or we can do immunohistochemical stains on it if there's not enough for a cell block, which is the last one at the bottom. So cell blocks are when you have a large sample that you've rinsed, and it's cut in paraffin just like when they have their thyroid taken out for surgery. It's made into a pellet and placed into a paraffin block, and sections are cut from the paraffin block, and it's stained with an H&E just like we do surgical samples. The slide preparation has the two techniques, one being an air-dried slide, which is the slide you're going to do today. That lets us do the Diffquick or the modified Wright-Giemsa stain. This does produce some distortion of the cells, so it takes a little getting used to. It makes the cells look a little bit bigger, so a little bit more pleomorphic. If you're not used to looking at DiffQuick, sometimes it makes things look a little scary. The alcohol fixed ones, or if you use a spray fixative, that's the same thing. Those are your slides that go for the pap stain. Pap stains provide a whole lot more nuclear detail, so when you hear the descriptors of fine powdery chromatin, nuclear grooves, and pseudo-inclusions, all those are the good descriptors that your people are appreciating from the pap stain for those papillary thyroid cancers. The DiffQuick itself is orange and blue in color, and it makes the cytoplasm have kind of a bluey pink look to it, and the nucleus gets very purple, very dark. So that's why it's hard to see much inside the nucleus as far as detail goes. But it's a great stain to appreciate just what types of cells are there. So it's good for in the clinic to do adequacy. The pap stain, on the other hand, we like to have because it's got such great nuclear detail. So all those beautiful grooves and inclusions are much more crisp, and it lets the cells be appreciated for the subtleties that you can see with Graves' disease and things like that. So it gives you much more fine detail. The last stain that is at times used is the H&E stain, or the hematoxylin and eosin, and that's actually just used for those cell block cases or surgical pathology. So when the total thyroidectomy is done and the specimen goes down to surgical pathology and it's put into cassettes and slices, the paraffin blocks from that are sliced, and the slides that come out have the H&E stain on them. This is what the setup will look like over there. So your first container is going to have alcohol in it. When we go across to the other room, it's actually going to be slightly tinted blue just to keep it separate from the water. The next one is going to be your orange G, and depending on who you order from, sometimes it's called fast orange. And the last one, this blue-purple, is your hematoxylin. And again, these are just the containers that I put the slides in. You'll see one over there. I think in the other room it's got a pink or a purple top on it. It's got alcohol in it. That's what I put my slides in for my pap stain. The empty container then holds the stains that are either air dried and stained in clinic to be looked at, or just air dried and sent off. So I'm going to show you real quickly how the book method is done, since it's a little bit different. When we go next door, you will have the opportunity to practice both methods. You can do the book and smears if you'd like. So to start with, when you do the book method, you want to start with the sample more in the center of the slide than like when we do a smear and you start down further at this end. So you put that small drop in the center of the slide. You're going to take the two slides and put them together kind of like a sandwich. So I take the labeled sides and put them together. And you're going to see that. So the sample's sort of getting squashed between the two slides. You're just going to let capillary action pull it apart as far as it'll go. At that point here, I'm going to outline where the sample is. Let's go back one. So you can see the sample has spread out like this. And now you take the slides and you open them up like a book. So that's why it's called a pop apart or a book method, because it makes a little pop when you open it, and you open it up just like you would open up a book. So when we do a smear, what's the difference? When you do a smear, you want to start, here's my labeled end, you want to start with the sample closer to the labeled end so you have further to pull the sample across the slide. There's a couple different ways to make smears. I can tell you the reason I like the book method is because I can end up with two slides from the same pass. If I see funny cells on the DiffQuick in clinic from the one pop apart, I can go to the pap stain when I get into the lab and look for those same funny cells that are going to have much more better or much clearer nuclear detail, okay? In a smear, there's two ways to do a smear. This way that I'm going to show you produces just one slide, and I'll try and show you over in the other room how you can do a smear that produces two slides, okay? But to do this one, you're going to place the sample closer to the end. You can either bring the slide up in front of it and pull it across the slide, or you can put the slide behind it and push it across the slide. You can use the long side of the slide to do the same thing, but when you do this, you're using the glass really to pull into the sample and let it spread across the distance of the slide here, and then pull it across so that you get a nice even layer. Here, I'll highlight where the sample is, and then you'll see a stained version of it, and it kind of starts here and goes down and angles across back up like this. So this is what it looked like stained. because you let the sample pull into the slide and get dispersed across the edge of it. You get a nice edge here. You're trying to keep a smear. This one went over to the edge, and I'll explain why we don't really want it to go to the edge. What you're trying to do is get a smear to stay within these confines here, sort of away from the edges, not into the frosted part, and not past these plus signs or whatever your mark is at the end of the slide. When the slides are finished in lab, there's a glue that goes on top and a cover slip. So the glue and the cover slip kind of line up at the edges of the slide, and we really can't focus in and out of the glue and the cover slip to see the cells that get stuck at that edge. So you lose some cellularity if your sample spills over onto those edges. So you're trying to keep it in more the center confines of the glass. So what are we going to do with this diff quick? You need to get your sample and air dry the slide. I'll go through that with you. You're going to place it into the 95% alcohol for about 30 seconds, and then you're going to move it over to the orange for approximately 30 seconds, and then into the hematoxylin for about 30 seconds. You're going to see a fourth container over in the other room because that's the water just to dip and rinse the excess slide off. When I'm in clinic, I usually have my stain set up next to the sink, and I just rinse under the sink water. What are we using this for? Well, we're going to use the diff quick ultimately to assess for adequacy. And everybody says, well, what if I already have a really good adequacy rate? Well, that's even better. My next question is usually, are you doing 5 or 6 passes to make sure you have a good adequacy rate? Because what you can do with this then is use it to see if after 2 passes you have an adequate sample so that the patient doesn't undergo so many needle sticks. So we're going to look for cellularity. We're going to look at the different cell types that are in the slide. The diff quick lets you appreciate colloid a whole lot better than the pap stain does, so you're going to be able to see that. And it does allow for architectural fragments to be seen. So if you have papillary fronds or psammoma bodies, all those things will be appreciated on the smears as well. If you do the rinse method where it does the just the single slide, you send the tube off to pathology. What happens with those is it's, bless you, a membrane that pulls the liquid up to it, and it filters out the big things like psammoma bodies and architectural or papillary fragments. So you lose some of those if you're doing just a liquid-based method. The next thing we need to discuss is what's adequacy. And unfortunately, there's many definitions of adequacy out there. So if you look at this, we started in the 80s saying, well, maybe we need 5 to 6 groups of well-preserved cells, and a group should have 10 to 15 cells in it. We then went on to say, well, really, maybe we need more than 8 cell groups, and they should have at least 10 well-preserved cells in it. And when we talk about cells, there's many cells that you can see within an FNA, but the only ones that count towards adequacy are the epithelial components, because that's what makes your cancers, right? So it has to be follicular cells or Hurthle cells that you're counting for clusters. The good news is that epithelial cells are the only things that cluster together good. So your mimics, like lymphocytes, unless you have a very aggressive FNA, are typically much more discohesive. There'll be single cells all over the background and smeared through things. The things that mimic for the Hurthle cells are the macrophages, and they're going to be slightly bigger usually, and they're not going to be stuck together in groups. They're going to be single cells or just loosely cohesive clusters around. So if you look for the big areas where the cells stick together, those will be your epithelial components. So we'll get on to what the final definition of adequacy has ended up being. I'm going to jump to the bottom for a minute. This was one that came about that has sort of gone to the wayside when the top definition came out of 6 to 8 groups of well-preserved follicular cells, 10 or more cells per group came out. That's the one we've landed with. That's really what everybody is using currently as far as a definition of adequacy. But when that came out, people thought, well, shoot, that doesn't sound like a lot of cells for a 6-centimeter nodule. The next definition came out, which was 6 groups of follicular cells on at least 2 slides from separate passes with a minimum of 10 clusters. You know, it got very confusing. So the discussion came up, well, adequacy means that you have an adequate sample. It doesn't necessarily mean that you've adequately sampled the nodule. So while this is a definition for the pathologist to say that they have enough cells to look at, it's up to the person obviously performing the FNA to know that they've adequately sampled the lesion, because sometimes throughout some large nodules, they don't look the same in different areas. So if you feel like you need to sample different areas of it, that's a different question. So what we want to look at now is just what some normal follicular cells look like. They typically have very round nuclei. They'll be in a honeycomb pattern like this if they're in a single layer. If they're three-dimensional clusters, they'll sort of be overlapped like this, but you'll see them through the dimensions. They typically have nice, fine, lacy cytoplasm like this. This is an example of abnormal follicular cells. Now you can see that they're much more elongated. They're not nice and round. The cytoplasm's harder to see. They have little points on them. They have fine grooves if you look here. There's another groove over here. Even though this is a Diffquick, we can appreciate some of those features. We can see tight little follicles that are kind of back to back. This was a follicular variant of papillary thyroid cancer. Now, if you've looked at your reports and read the little microscopic descriptions at the bottom, you've probably seen things that describe microfollicular patterns. This is an example of microfollicles here and up here. A microfollicle is defined as something that's 7 to 15 follicular cells making up a tiny follicle. The really little ones sometimes don't have any colloid in the center, and the larger ones will sometimes have this more dense, inspissated colloid sort of in the center of the follicle, like this. These are your Hurthle cells. Hurthle cells are slightly larger. They have more cytoplasm. If you look at the cell itself, the nucleus is towards one side and the cytoplasm is towards the other side. It's a granular cytoplasm. The nucleus is still fairly round. Hurthle cells in and of themselves will at times have grooves, so not all grooves are bad indicators. Here's another example of Hurthle cells. Now you can see the granular cytoplasm just a little bit better. And the other thing that the Diffquick does, it lets you appreciate the thinner, finer colloids. So this is the two thinner colloids. This is called the watered silk pattern. Those of you familiar with fabric, you know, if you take a piece of fabric and you drop it, it kind of gets all those wrinkles in it. That's how this got its name. And this is called fluffy colloid, because to me it kind of looks like a cloud. So those are the other types of colloid you can see. Here's your mimics. So these macrophages look a lot like Hurthle cells if you think of the descriptors that I use, in that the nucleus is to one side, cytoplasm to the other, and there's granules in the cytoplasm. Well, the good news here is, see how you see space between the cells? So they're not a tight, cohesive cluster. They are slightly bigger usually. The other thing is, if you look at the cytoplasm of them, the granules are not really granules, they're lysosomes and vacuoles, because it's cleaning up, right? So the granularity of it is much more irregular. Sometimes it's dark spots, sometimes it's light spots. Just depends on what it's cleaning up, okay? So that being said, we're going to try doing some FNAs on liver across the hall. You're going to either practice making a book method or a smear, both if you'd like. We'll stain one of those slides, and you'll pass it off to my colleague at the microscope, and she'll show you whether you got enough adequacy from the liver FNA. And then she has some teaching slides that have follicular cells and Hurthle cells and that type of thing. There's a computer over there with a PowerPoint that'll run through some different thyroid lesions, some with Diffquick and some with Pap stain, so that you can see the difference in the nuclear detail. Stephanie, what do you want to have happen at this point then?
So welcome again. I'm going to go through a basic review of thyroid ultrasonography, and then I'll be followed up by Dr. Fish with a more advanced lecture on thyroid ultrasonography. We're going to cover regular neck anatomy, normal neck anatomy, review the literature on palpation versus thyroid ultrasonography, as well as review the basic nodule characteristics on ultrasound. And then Dr. Fish will follow up with FNA technique, lymph node evaluation, and parathyroid imaging. So in general, thyroid ultrasonography, as many of you know, uses high-frequency sound waves to take a picture of the thyroid gland, and that is then conveyed into an image that we can see. We usually image using a frequency of between 5 to 14 megahertz. The higher the megahertz, the better the resolution. The lower the megahertz, the worse the resolution, but the greater depth to which the ultrasound waves penetrate. So for those of you that are experienced in thyroid ultrasonography, you'll use the higher frequency to scan thinner necks and get greater resolution. If you need to go deep for some of the deeper, larger necks or large lesions, you'll give up some of the resolution and you'll be scanning at a lower frequency. So, and that's here. In general, the patient lies supine with the neck hyperextended, quite uncomfortable sometimes for the patient, but necessary for us to get the ultrasound probe in there and get a full image of the thyroid. We apply ultrasound gel to facilitate the transmission of the sound waves. We mentioned the resolution using the linear array transducer, and we scan the neck both in the longitudinal and in the transverse planes. In terms of normal thyroid anatomy, the thyroid is in a butterfly shape with two lobes, a superior and inferior pole. The superior pole, as we'll see in a minute, is more rounded and a more elongated inferior pole. Lobe dimensions vary greatly amongst patients, but usually 4 to 6 centimeters in length and approximately 2 centimeters in diameter. And a normal thyroid is approximately 10 to 15 cc's. So looking at an ultrasound image of the thyroid with the corresponding anatomy in a schematic below it, we have the trachea, we have the esophagus, which we should always be aware of. The vasculature is lateral to the thyroid in this transverse view, with the carotid more medial and the jugular more lateral, surrounded by different neck strap muscles, sternocleidomastoid muscle, the sternohyoid muscle, and other muscles that lay in the central compartment of the thyroid, of the neck. Now looking at thyroid ultrasonography in longitudinal scanning direction, as I mentioned, we have a superior and then an inferior pole with a more rounded superior and a more elongated inferior pole. We begin to scan more medially, where you see the tracheal cartilages, and then scan laterally, where you see the thyroid, and then you continue further laterally and you begin to see the vessels that we mentioned. So on that, when you get past the thyroid laterally, you'll begin to see the carotid or the IJ. And going back to the previous picture, if you start in the middle and you're scanning up and down, you'll see the trachea, then you'll see the thyroid, and then you'll get to the vasculature. So how can we use thyroid ultrasonography in the diagnosis of thyroid nodules? This is some early data from Dr. Mazzaferri in the early 90s, comparing ultrasound diagnosis or detection of thyroid nodules compared to palpation, and showing a significant difference in our ability to detect nodules. Most of these smaller nodules, but as we'll see in a few minutes with some data that I'll show you, also missing larger nodules. With a nice number to remember, ultimately approximately 50% of 50-year-olds, if scanned, with an ultrasound, will have some type of, will have a thyroid nodule detected. In terms of age and sex predilection, as we go up in age and as we look at men and women in each of these age groups, we can see that as we age, we have a higher prevalence of abnormal echo pattern, including thyroid nodules, and women dominate men in terms of the prevalence at every age group. So how is thyroid ultrasonography helpful? Well, maybe we can easily detect this large superficial nodule, but maybe on palpation we miss this deeper, smaller nodule. Likewise, maybe we miss this larger but deeper in a neck with a large neck, deeper nodule. This, even though it's large and 1.5 centimeters and could be easily palpated in a thinner neck, might be missed when palpating a larger neck. Or, and this is a different problem, a false positive problem, maybe we think that this is a nodule, but this is really a pseudonodule in a heterogeneous autoimmune gland. So what nodules are we missing? Ultrasound versus palpation, as I mentioned earlier, the majority of the lesions that will be missing, 94% or so, are of the small variety, under a centimeter, but we're also missing a good number of the larger lesions, likely because of positioning, larger necks, deeper positioning. So this led both the American Thyroid Association as well as the combined ACE, South American Thyroid Association and European Thyroid Association to include in their guidelines the recommendation to perform thyroid ultrasonography in essentially all patients suspected or known to have thyroid nodules. So thyroid ultrasonography should be performed in all patients with known or suspected thyroid nodules, a recommendation class A from the ATA, and in all patients with palpable thyroid nodules or multinodular goiters, an ultrasound should be performed. Here a class B recommendation by the groups that I mentioned. So now what characteristics of nodules do we look for in a thyroid ultrasound to try and suggest a diagnosis or raise concern? We're interested in echogenicity. We're interested in calcifications, in how the nodule sits within the thyroid, whether there are clear margins and a nice halo effect, and also looking at vascularity, and we'll look at each of these separately. So first, calcifications. There are many different types of calcifications, some with a benign connotation, some with malignant connotation, and some that could go either way. And so we'll look at these one by one. If they're highlighted in white, and I'll mention it, they can go either way. They can suggest malignancy or benignity. If they're highlighted in green, they're usually benign, and the red ones, the red highlighted boxes, will always be suggestive of malignancy. So first we'll deal with an eggshell calcification. As you can see here, this nodule having what appears to be calcification around the periphery of the nodule, and it's unclear. Initially we thought this to be a benign finding, but it's been found in malignant thyroid nodules, and so this could go either way. Then we have coarse calcifications. So these are clear, large, solid calcifications seen in thyroid nodules and associated with a post-calcification shadowing, a clear shadow behind the coarse calcification, as we can see in these two lesions. And this again is highlighted in white because it could go either way. They can be found, these coarse calcifications, in benign adenomatous nodules, but also in malignant nodules, and more frequently in medullary carcinoma. Now in green, almost always or always predominantly suggesting benignity, are these punctate calcifications with what we call a comet tail artifact. So that is a hyperechoic focus with this comet tail artifact, this tail, not a shadowing, but a tail that runs down beneath the apparent calcification. These are thought to be concentrations of colloid. Not 100% sure, but they suggest benignity. In reports, in order to see the comet tail artifact, you often need to drop the frequency from the higher to the lower frequency. Doesn't always work out that way, but that's what's reported. But if a comet tail artifact is reported on an ultrasound report, that suggests benignity if it's not mentioned. And if you're doing the ultrasounds yourselves, to try and see the comet tail artifact, if you're trying to distinguish between a clear punctate lesion, which we'll see next, is suggestive of malignancy, you may need to drop the frequency to see the comet tail. So now moving on to the punctate calcifications that worry us the most, we can see in these two pictographs these microcalcifications, no post-calcification shadowing, and no comet tail artifact. These are what we worry about most in terms of suggestion of malignancy and are likely to be found in papillary carcinoma, and we believe, although it's never been clearly shown, that they're associated with the psammoma bodies that we often find in papillary thyroid cancer. Okay, so now what does a sonographically benign nodule look like? So we talked about the echogenicity, so if the lesion is isoechoic versus hypoechoic, and if the lesion has a nice round halo around it, and if we have peripheral vascularity as we see in these images. So nice vascularity, hypoechoic, nice halo, likewise a nice smooth halo and peripheral vascularity, suggestive of a benign nodule. Also what we call spongiform nodules. These can be difficult to diagnose sometimes, but they give this spongy appearance as depicted in the picture here on the left, associated again with the peripheral vascularity. And also, when we talk about vascularity, as we'll see in a moment, when we look at malignant nodules, is a negative predictive factor unless you're dealing with somebody who's hyperthyroid and may have a Graves' gland where hypervascularity throughout the gland can be seen. So now sonographically suspicious nodules will be the opposite of what we've discussed to this point. So hypoechoic, irregular margins, punctate macrocalcifications, and intra-nodular rather than peripheral flow. So here's an example of that type of a nodule. So a nodule without a nice halo and with irregular margins appearing to be invading into the surrounding tissue. Likewise, a second example. Another example of a nodule without a nice halo, irregular margins, and now we're seeing these punctate calcifications that we mentioned as being worrisome. And now this is a complex lesion with intranodular flow to a region of the complex lesion, and then another nodule here with clear and obvious increased vascularity throughout the nodule. Now, having said all this, approximately about the ultrasound characteristics, still 66% of benign nodules will have at least one positive ultrasound predictor of malignancy, and 66% of papillary cancers will have at least one non-suspicious ultrasound feature. So when we look at the data with regard to the sensitivity, specificity, positive and negative predictive value of these ultrasound characteristics, we see that specificity is not great, but can sometimes approach numbers that would be satisfactory clinically, but sensitivity is very low. And of course, for a screening test, what we look for is high sensitivity. And so that's where we still must rely on our FNA, which has a very high sensitivity and a very adequate specificity. So the way we currently use the ultrasound and the ultrasound characteristics that we mentioned are to assist us clinically, but ultimately we rely on an FNA. And so this is from the ACE, ETA, AME guidelines that I mentioned earlier, suggesting how to risk stratify lesions based on their mostly their echographic characteristics in terms of our suspicion going from weak to strong. So be dealing with purely cystic lesions, which the recommendations are to leave alone until they're greater than 2 centimeters, and then spongiform moving up to microcalcifications, irregular margins, abnormal lymph nodes or clear extracapsular invasion, all the way to a very high, strong suspicion for malignancy. So complementary to our and a tool to be used in our diagnostic algorithm, with FNA being the ultimate determinant of malignancy and the diagnosis. So that's what I had for you in terms of a basic presentation. If there are any questions, I can take questions. Otherwise, we'll move ahead with Dr. Fish, who will present the advanced thyroid ultrasonography lecture.
So what we're going to do from now that Andrew has gone over the basics of ultrasound and diagnostic ultrasound, I'm going to move it the next step, and we're going to look at fine needle aspiration and utilizing ultrasound in our guidance for fine needle aspiration. I'm going to talk a little bit about the evaluation of lymph nodes, especially in patients with thyroid cancer. And I'm going to end with the utilization of ultrasound in the evaluation of parathyroid glands in patients with primary hyperparathyroidism. So we're going to start with fine needle aspiration. And this is a summary of a table from the 2009 ATA guidelines for the evaluation of thyroid nodules and thyroid cancer. Just so you all know, they are currently at this meeting putting together the next level of guidelines, which will be published in 2013. So these are the guidelines that we're using right now, but they are changing as we get more information and data. There will be more new recommendations next year. But the key here is that what you notice is that the recommendation for which nodules to biopsy is based on a risk assessment. So that nodules that are highest risk, which are those patients, those nodules with very suspicious findings, as Andrew just went over, with microcalcifications, irregular margins, hypervascularity, those are nodules that even if they're fairly small, you should consider biopsying. May not biopsy all of them, but it's something to think about. In an ultrasound, if you see abnormal lymph nodes at all, no matter what the nodule looks like or the size, that's something that should be biopsied if someone's presenting with abnormal lymph nodes. But now, as we have fewer of these characteristics, our cutoff for biopsy is going to change. So that if there are microcalcifications or the nodule solid and hypoechoic, greater than 1 centimeter is about a size to consider a biopsy. But as we move higher, if you have a spongiform nodule, a nodule with little mixed cystic and solid areas, we're not going to that nodule's most likely benign. The only reason to biopsy would be if that nodule was quite large, greater than 2 centimeters. So that based on the appearance and the risk is going to help us decide which nodules to biopsy. So there's not one cutoff for every nodule. If a lesion is a pure cyst, total cyst, no solid component at all, that's a lesion that should never be biopsied. It may need to be drained for symptomatic purposes, but you're not going to need cytology. Something that's a pure cyst is always going to be benign. Today, really the vast majority of biopsies are done with ultrasound guidance, but in your training, you may still be doing some biopsies by palpation, which, if the nodule's clearly palpable, that's just fine. But in nodules that are difficult to palpate, in nodules that are very posterior, as Andrew showed some examples, in nodules that are mixed cystic and solid, really utilizing ultrasound to guide the needle is going to be very important in order to get a diagnostic specimen. And then if you have a nodule that was biopsied without ultrasound guidance and the final result, the cytology, was non-diagnostic, that nodule does need to be rebiopsied, and in the repeat biopsy it should be done with ultrasound guidance because as a whole the non-diagnostic rate is much lower when ultrasound guidance is used. Are you guys learning to do biopsies by palpation at all? Can you guys raise your hands? Okay, a few still. And how about how many are you doing them mostly with ultrasound guidance? So, I think that that's the trend, and there's really more of a movement to use ultrasound because they're becoming so prevalent, but especially in practitioners who've been doing it for a long time and are used to doing it with palpation, it's certainly reasonable, but every patient should still have an ultrasound. You still want to look at that nodule and you want to evaluate it with ultrasound, even if the biopsy's not going to be done with ultrasound. And then again, if you've got a nodule that's been evaluated and it was benign but it's growing, growing or changing and you just question the result of the initial biopsy, again, you can be a little bit more confident in the result when you use ultrasound guidance because you've got an eye on your needle the whole time and you know that you've definitely biopsied the nodule. So here are just some examples. Here we can see this nodule that is palpable. You can see that the right side of the thyroid is raised because of this nodule, but it's very deep within the thyroid gland, and it's very possible that if you just do a biopsy by palpation, your needle's just going to go in that superficial, normal part of the thyroid gland up here, and you need to really get your nodule all the way down your needle all the way down into the nodule. So with these very deep nodules, ultrasound guidance is really helpful to ensure that you've truly biopsied the nodule. And here's a nodule. It's somewhat irregular in borders. You don't see it super well, but it's deep as well, and there's a lot of normal tissue anterior. So using ultrasound guidance is going to be important in the biopsies. And then here's an example of a nodule that's predominantly cystic, but it does have these little solid parts to it. And again, when you put on the Doppler, you can see this is really viable tissue. This is a lot of debris. To biopsy this, if you stick the needle if the needle's over here or over here, you're not going to get any viable, useful tissue. You need the ultrasound guidance to direct your biopsy right to this viable vascular tissue at this end of the cyst. So this is just some data. They have looked at the false negative rate, comparing palpation FNA to ultrasound guided FNA, and these two studies that are now quite old, but you can see that the rate with palpation was as high as 2%, as low as 0 to 0.6% with ultrasound guidance. So that's where if you do have a non-diagnostic FNA with palpation, the repeat should be done with ultrasound guidance, and you're getting much fewer false negatives when you use the ultrasound guidance. So the technique that you use to do these biopsies, there's different options, and you will have a chance to practice your ultrasound FNA over in the other room. In most people who are in practice, when they're starting out, it's me, myself, and I. You're by yourself with your ultrasound machine. So generally, the one-person technique is what's used, where you're holding the probe in one hand and the needle in the other hand. As there's more experience, often when you're doing your training, you'll have the option of having someone else hold the ultrasound probe for you, get you in position, and then you just have to focus on the needle, which I think to me is a preferred technique because you just are only thinking about one thing at a time. But either way is absolutely appropriate. So when you're doing a biopsy, you don't need any special material. You need a needle. Generally, we are using 25 to 27 gauge needles in doing the biopsies. The longer the needle, the better, especially if you have a nodule that's fairly deep. So generally, at least 1 1/4, ideally 1 1/2 inch needles. We generally attach it to a syringe. Some people do biopsies with the needle alone in their hand. The technique I use is I have the needle attached to a syringe. You want to break the seal and put about a cc of air in the syringe. And then, you don't really need a probe cover or sterile gel or anything like that, but you can use it if you need to. And you just clean the neck with some alcohol. And you don't need any of the special needle guides or things like that. A freehand technique is absolutely fine. A needle on a syringe, using the ultrasound, and then moving the needle throughout the nodule. The cells will come up in the needle by capillary action. You don't have to pull back on the syringe at all and aspirate. And here's just some techniques. And this you'll learn better over in the practical session. But with the linear probe, there's really 2 possible techniques. The parallel technique, where you hold the probe across the neck. Your needle's going to go in right along the side of the probe. And the perpendicular technique, you hold the probe across the neck this way, and the needle's going to go in at the midpoint. With the parallel technique, the idea is that you can really keep the whole needle in your field of view throughout the process, whereas with the perpendicular technique, you're just going to see the tip of the needle. You're not going to see the whole line of the needle. So here's an example just on cartoon form of that parallel technique. You've got your linear probe on the neck, the nodules right at the mid portion here, and your needle's coming in right along the edge, right along here. And then on the ultrasound, you're going to see it's not perfect, but you can see the line of your needle here coming right into the nodule. There's the tip, very clearly visible. On the other hand, with the perpendicular technique, you're lined up the same way. You've got your nodule, but here you're going to stick the needle in right at the mid portion, and you're going to see just that tip of the needle inside your nodule. You're not going to see the whole line of the needle. Both adequate techniques. This one is a little better in that you really see the whole needle, but this technique is perfectly acceptable as well. Another option in your biopsies, this is to use this is with the linear probe, but you can also use a curvilinear probe, which is just a rounded probe, and it allows you to use a little bit of you get a shorter distance to the nodule with the curvilinear probe. Sorry, so here's just an example. Here's the nodule. Oops. With your curvilinear probe, you're going to put it on the neck. You see the nodule, and your needle's going to come in straight through, and you'll see it right in the nodule. It's just a different technique. This is a probe that any radiology department will have. An ultrasound in the office likely will not have this probe, but in your radiology department, if you're doing any biopsies there, they will have this small, they call it a baby head probe. It's a different technique. It can be helpful in a big gland when you need to get a little deeper. In areas that are hard to get to with the linear probe, the curvilinear probe is just another technique which allows you some additional flexibility in your biopsies. So once you've done your biopsies and you've found your cytology and a patient the final cytology shows papillary thyroid cancer, the next step before you rush the patient to surgery is you want to look at the lymph nodes. Up to 40% of papillary thyroid cancers can have lymph node metastases at presentation, and so you want to evaluate those lymph nodes before surgery so that you make sure that the extent of surgery is most appropriate. So 42%, I went ahead of myself, 42% have lymph nodes at diagnosis. 21% present with macroscopic lymph nodes. So often, almost half the time, those lymph nodes are there, but they're microscopic, not necessarily clearly visible on ultrasound. But it does appear that at the time of diagnosis, somewhere between 20 to 40% are going to have lymph nodes, at least 20% of which are macroscopic lymph nodes. And so, as part of the current ATA guidelines from 2009, there is a recommendation that a preoperative neck ultrasound for the contralateral lobe and the cervical lymph nodes is recommended for all patients who are undergoing thyroidectomy for malignant cytology. An ultrasound-guided FNA of sonographically suspicious lymph nodes should be performed to confirm malignancy if this would change the management. And so that you should do that additional ultrasound before the surgery, especially if you do find lateral lymph nodes. That really does change the extent of the surgery. Central lymph nodes a little bit less, so those will generally be seen at the time of surgery and be removed by the surgeon. So the key here is recognizing on ultrasound what does a normal lymph node look like and what does an abnormal lymph node look like. So normal lymph nodes are generally oval in shape. They have something, and as you see ultrasound reports, they're going to describe lymph nodes, so you want to know if they're describing normal or abnormal. The other normal thing you'll see is you'll see an echogenic hilus, or a fatty hilus. And so on an ultrasound report, they'll often describe a fatty hilus and with hilar vascularity. So a normal lymph node, this is a perfect normal lymph node. You see the oval shape, and you see this bright white stripe right in the middle. That's the fatty hilus. Otherwise, hypoechoic and homogeneous oval. And when you put on the Doppler, it's hard to see. You don't have a lot of blood flow in a normal lymph node, but where you'll see that blood flow is right in that echogenic hilus. So that fatty area in the middle is right where a normal blood flow is going to be. This is a map of the lymph nodes and the levels of the lymph nodes. And it's very important that you understand when you're dealing with thyroid cancer, the surgeons think about lymph nodes based on these levels. And their dissections and lymph node dissections are going to be based on the level. The central neck right behind the thyroid gland is level 6. And then as we come to the lateral neck, we've got level 2, 3, and 4, and level 5 is more posterior. And so it's important when you're doing your ultrasounds that you're able to describe the location of the lymph node, because it can be very helpful to the surgeon so that they know where to look of where the abnormal lymph nodes are going to be located. Level 1, which is right under the chin, is a very unusual place to ever see thyroid cancer. So now what are we looking for when we're looking for abnormal lymph nodes? Instead of the oval shape, a metastatic lymph node is going to be round. That echogenicity with metastatic papillary thyroid cancer, it may be hyperechoic, a brighter lymph node, but that's not universal. That hilus disappears. So the absence of the fatty hilus is suspicious. It can have cystic change. It can have microcalcifications as well. And generally increased vascularity, more peripheral vascularity as opposed to that central vascularity. So if you see a round lymph node with no echogenic hilus and peripheral vascularity, very suspicious for metastatic disease. So let's look at an example here. This is the patient's thyroid gland. This is a nodule with irregular borders and some calcifications. And this was here lateral to the thyroid gland. Here's our carotid artery. And lateral, you can see this rounded lymph node, which is hyperechoic, a little bit brighter than the thyroid gland, and it lacks a fatty hilus. So this at presentation, we know already that this nodule is not good because already we see the abnormal lymph node. And in this situation, you could just biopsy the lymph node, and if it's papillary thyroid cancer, then the surgery would include the total thyroidectomy as well as the lateral neck dissection. Here's another example. This nodule itself has very irregular margins, microcalcifications, it's hypoechoic. Just looking on ultrasound, this is a suspicious nodule. But in addition, as you do further ultrasound, we see this rounded lymph node lateral to the neck. And here's a great example of that peripheral vascular flow in an abnormal lymph node. So this is clearly a lymph node that is sonographically suspicious. So it's round, lacks the fatty hilus, microcalcifications, and peripheral vascularity. It's got everything. And so again, in the guideline recommendations, so what do we do when the ultrasound detects the abnormal lymph node? And if a positive result would change your management, then the lymph node should be biopsied and evaluated. The key here is that, as I said, at least 40% of patients with thyroid cancer have lymph node disease. Every lymph node doesn't have to be treated and removed. In patients with thyroid cancer who have minimal residual disease, they may have small abnormal lymph nodes that may be monitored for a period of time. Single small amount of lymph nodes don't necessarily always require surgery, and we do sometimes monitor lymph nodes rather than rush to surgery. So we have to also put it in a clinical context to determine which lymph nodes need to be evaluated. Okay, so this is sort of a very general overview, and I want to just end with a touching on the idea of using ultrasound for hyperparathyroidism, because we all see lots of patients with hyperparathyroidism. It's a common disorder in the United States, and most patients with hyperparathyroidism are asymptomatic. Most patients have a single adenoma, and the key is in these asymptomatic patients, who do we send for surgery? And this is just a summary table that puts together the recommendations based on NIH consensus conference for patients with asymptomatic primary hyperparathyroidism. And based on the most recent guidelines from 2009, elevated serum calcium, low creatinine clearance, and osteoporosis, as well as young age, are all indications for surgery. And the key is that surgery today ideally should be minimally invasive. Traditional parathyroid surgery had always been a 4-gland exploration. You check all the glands, you remove the abnormal gland. But this surgery was long and it was associated with a lot of postoperative hypocalcemia. And so the technique today that's favored is minimally invasive with a unilateral approach, an excision of a preoperatively identified abnormal parathyroid gland with intraoperative monitoring of the PTH level. It's shorter surgery, smaller incisions, and fewer complications. But the real key is that you really have to identify the abnormal gland preoperatively, and that's where the imaging studies come into play. The other issues with this surgery is if a patient has one more dominant adenoma but really does have multi-gland disease, with a unilateral approach you can sometimes miss multiglandular disease. So ultrasound is just one of the imaging techniques that can be used to identify parathyroid adenomas. And this is just an example on ultrasound of what a typical parathyroid adenoma will look like. You see this hypoechoic, homogeneous lesion just posterior to the thyroid gland. So here's our thyroid, here's our trachea and our carotid, and this lesion just behind the thyroid gland shouldn't be there, and in the right clinical setting would be high suspicion for a parathyroid adenoma. And then we look on the sagittal view. So here we have the thyroid in the longitudinal or sagittal view, and again we see this homogeneous lesion just off the posterior end of the thyroid gland. This is very typical ultrasound appearance for a parathyroid adenoma. So just in cartoon form, on the transverse view, we'll see that parathyroid adenoma just behind the posterior aspect of the thyroid gland. And here it is on ultrasound. Trachea, thyroid, here's our parathyroid adenoma. And on the sagittal view, it's on this view that you can really try to distinguish superior from inferior parathyroid adenomas. An inferior parathyroid adenoma is just going to be off the inferior pole of the thyroid on sagittal view, whereas a superior parathyroid is going to be at the midpoint, still behind the thyroid gland, but at the mid-pole of the thyroid gland. So here's an example of the location of where we might see a superior parathyroid adenoma. Again, you can see these regular borders, oval shape, hypoechoic and homogeneous, but right sort of equal amount of thyroid above and below. Whereas here's an inferior parathyroid adenoma just off this inferior pole of the thyroid gland on sagittal view. So the last thing when you're looking for these parathyroid adenomas is you're going to look at the vascular pattern. Sometimes these adenomas can be confused with lymph nodes. So if you remember, I told you a normal lymph node has a hilar vascularity right in the center. Metastatic disease in a lymph node has peripheral vascularity. A parathyroid adenoma has a polar vascular pattern with a single feeding vessel into that parathyroid adenoma. So this vascular pattern can again help you to distinguish if you're not sure exactly what the lesion is. And here's another example of this polar feeding vessel into the parathyroid adenoma. So the keys here in the right patient who has clear biochemical hyperparathyroidism, you really think surgery is indicated, the ultrasound can be helpful in localizing the parathyroid adenoma. We're looking at the key issues here are the appearance, which will be oval, homogeneous, and hypoechoic. The location, superior is just behind the midpoint of the thyroid, and inferior just off the inferior pole of the thyroid. That polar vascular pattern, and then experience as you have access to the ultrasound machine. Using it on your patients with hyperparathyroidism is worthwhile just to kind of get a sense of what you can see and how you can identify these parathyroid glands. So with that, I'm going to stop. We're going to transition everyone who would like to do the whole session over in the other room, the hands-on session. We're going to move over in about 5 or 8 minutes or so. in anyone who feels that they do a lot of ultrasound and don't necessarily need to do the diagnostic or the ultrasound FNA, but would like to do the cytology station only, you're welcome to go over next door right now and do the cytology station before Dr. Massoll comes over to give her lecture again. Okay?